Sorry, the thing is at the top. Okay, let me move it down. Okay. Um, so hi everyone, my name is Sajani. I'm a second-year medical student at VCU School of Medicine. Like Dr. Martin had mentioned, this past summer, I've been working with her and the Project SORT study team, and we've been recruiting women who are on buprenorphine for opioid use disorder and asking them about their experiences with sleep and to understand the factors that may affect sleep in this population. So today I'll be presenting on social determinants of health and insomnia in women receiving buprenorphine opioid use disorder. As some of you may know, sleep difficulties are common in people with opioid use disorder. These difficulties have been noted during the different stages of OUD treatment, and studies have shown that buprenorphine is associated with reduced sleep quality and quantity. Psychosocial factors impact sleep health, yet this intersection has yet to be studied in OUD patients. This is particularly salient as women face unique psychosocial factors that may affect their sleep and overall treatment outcomes. The main objective of the study is to report and compare the social determinants of health between individuals with and without insomnia among a sample of females receiving buprenorphine for OUD. So for the methods, this is a secondary analysis of data collected from an ongoing cross-sectional survey study investigating the relationship between sleep and recovery in OUD. The inclusion criteria were non-pregnant females between the ages of 18 to 45 that are stabilized on buprenorphine from an outpatient program. The primary outcome was to look if participants had insomnia or not, and we used the insomnia severity index with scores of greater or equal to 10, identifying clinically significant insomnia. The other variables we were looking at were social determinants of health that were compared between the insomnia groups using chi-squared and Fisher's exact for dichotomous variables and t-test for the continuous variables. The social determinants of health was taken from the Healthy People's Frameworks social determinants of health. And there's 5 different domains that we looked into. One was education level, looking if they had received a high school education or equivalent, economic stability regarding employment status, neighborhood and environment domain, looking at housing insecurity, health and healthcare domain, and we mainly looked at the cost incurred for seeing a provider, and the last one was social and community context. And the results were the participants were predominantly white with a majority of them on Medicare. The median daily buprenorphine dose was 24 milligrams, and the median length of time on the buprenorphine was 2.1 years. So table 1 is talking about the demographic characteristics among the women. So the mean age was 33 and a half. As I said earlier, the majority of patients are white and mainly on Medicare and Medicaid. There is a majority of our patients are also unemployed, and over half had received their high school or GED equivalent in education. So of the 42 participants, the majority met the criteria for insomnia with 51.7% of them. The participants with insomnia reported more concern over housing insecurity in the next 2 months with a p-value of 0.024 and being unable to see a doctor due to cost with the p-value of 0.029 compared to participants without insomnia. The other 3 domains, which were education, economic stability, and social context, were equal among both groups. And this data is shown in the table 2, looking at the psychosocial characteristics between women with and without insomnia receiving buprenorphine. And lastly, for the discussion, consistent with research in other clinical populations, insomnia, OUD, comorbidity exists in a complex socio-ecological context, and future research at the intersection of sleep dysfunction and OUD medication treatment should encompass social determinants in addition to medical and psychological factors. Thanks.
Great job, Sajani. Great job for opening us up. So I will open it up for any feedback that people have about the project?
Sorry. How do I do this? Oh, there we go.
I will just make a comment. I presented these findings actually at a talk I gave to some people at NIDA, so with the National Institutes of Health recently, and they were super interested in it. And so, and this focus on social determinants of health. So I took these numbers from you and presented them just at this little internal group. And they were really interested in this intersection. So I think this is a great area to focus on. I know I'm really biased because I designed the study to do that, but maybe one comment I will make just for your presentation is, it was excellent, is just to be more clear in the introduction of the rationale for the study, because it's clear to us because we are in the study, we're doing it, we're like in it. But just, being very clear, the purpose of the study is do this, getting this information is going to help us do blank, blank, and blank. And this is important because of blank. Just because not everyone will see the correlation. I don't understand social determinants of health, insomnia, opioid, like I don't really get, it is a lot of things at one time. So I think just making that very clear for people will be good.
Okay, thank you.
Yes, and Deshonda had a good point about using a graphic instead of a table. Ironically, Deshonda, I was taking notes for Sajani and I wrote that too. So the results, since they are so impressive, the differences just in your simple percentages, like in your table on the right, you can make that into some type of diagram. It will look really pretty on the poster. You can use different colors. You can have it in line with the healthy people framework. Yeah. Just kind of the bubbles that you have within the healthy people framework, and just show, put your data in that somehow. It'll really take home point. It will make the emphasis on those findings, which is your primary aim. So, and it's super interesting, and that's what you want people to focus on. So I would make a pretty figure for that table that's on the right.
Okay, I can do that. Should I just do should I do all 5 of them, or just the ones with like the clinically significant?
I would do all of them, because if the p-values, they're there because we have to do them, but really we're looking at are the numbers, right? The percentages, because it's a descriptive study.
Okay.
Any other feedback that people have for Sajani? Well, awesome job. You were off the hook.
Thank you. Thank you all for listening.
Great. Who is next?
I think I was next on the list. Don't mind going.
Yep. Thank you, Catherine. Make sure to introduce yourself.
Yes, well, let me see if I can get my screen to share. Maybe not. Oops, sorry. I'm having some issues getting my screen to share.
Do you want someone else to go, Catherine?
Yeah, maybe let's have someone else go, and I'll maybe try and come back in and out and get my screen to work.
Also, you can just email maybe the PDF or something to Bhushan, and he can share his screen if needed, or any of your lovely colleagues, in case it's a computer thing.
Okay, yes, I can do that.
Someone able to pitch it?
Yeah, I can go.
Thank you.
Let me this. Okay. Can everybody see that okay?
Yes.
Okay, amazing. Hi, everyone. My name is Sriya. I'm an M2 here at BC School of Medicine, also working on the Project SORT team with Michelle and all of the lovely other ladies. Huge shout out to Michelle and Bhushan for helping us put these posters together and helping us figure out our abstracts. I really appreciate that. So I'm presenting today about the role of cannabis use on clinical and psychosocial outcomes in women in treatment for OUD. So a lot of patients who are going through treatment for OUD will be using cannabis. It's something I noticed just taking patients' baselines, and also it's supported by literature. Patients in treatment for OUD uniquely struggle with sleep. Patients with sleep disturbances are also more prone to relapsing. Previous studies have also demonstrated that cannabis use has dose-dependent effects on sleep. Past work has also shown that patients with OUD and concomitant cannabis use present with a comorbid anxiety disorder. But less is known about cannabis use in a female population utilizing buprenorphine and its relationship with sleep and opioid craving. Specifically, females and buprenorphine have been severely understudied in this area of literature. So the purpose of the study is to examine the relationship between concomitant cannabis use in female patients using buprenorphine for OUD treatment, sleep, anxiety, opioid cravings, and withdrawal. So this was a secondary cross-sectional analysis from a survey study investigating sleep and OUD recovery. Our participants are non-pregnant females ages 18 to 45 that are stabilized on buprenorphine for at least 6 weeks in an outpatient treatment center. Participants were assessed for cannabis use utilizing a 28-day timeline follow back, and that was categorized into non-use, occasional use, and daily use. Non-use was 0 days, occasional use was 1 to 27 days, and daily use was using it every single day, day 1 to 28. Clinical characteristics assessed included the insomnia by the Insomnia Severity Index, anxiety by the Generalized Anxiety Disorder 7, pain interference ranging from 0 to 4, adapted from short form 36. OUD outcomes that were analyzed included subjective opioid cravings, subjective opioid withdrawal, which ranged from 0 to 100 for both. And then these were compared between the cannabis groups using a one-way ANOVA, and statistical significance was anything less than 0.05. So we had 42 participants who finished the surveys. They were predominantly white, 53.2% were white, and 94.9% of them, so almost all of them, had Medicaid or Medicaid for their insurance. So daily buprenorphine dose was 24 milligrams. It ranged from 6 milligrams to 24 milligrams. Average length was about 22.1 years, but it ranged from 21 days to 5 years. And cannabis use, so there was 21 participants who had no use, 12 participants who had occasional use, and 9 participants who were using it daily. So these were our results. So as you can see, for clinical insomnia, the cutoff is 10. So insomnia average score for all 3 groups were above the clinical. So regardless of cannabis use, these patients were having insomnia. Same thing for mild and moderate anxiety. So mild and moderate anxiety begins after a score of 5, and all of them were above that line. For all cannabis groups, pain interference was at least moderate, and opioid withdrawal symptoms and opioid craving. So the participants with occasional cannabis use reported higher intensity of opioid wanting or craving, and this was statistically significant. And opioid withdrawal, which was P of 0.11, than participants using cannabis daily or not at all. So in conclusion, amongst the sample, a high proportion of women with OUD also regularly use cannabis, and this may relate to an increase in opioid cravings, which has the potential to negatively impact their recovery. In this cross-sectional study, patient-reported OUD outcomes differed by levels of cannabis use, yet not by a dose response trend. And the limitation here was that we didn't know how much they were using each time they had a reported use. So in the future, future studies should look at qualitative and longitudinal data to investigate associations of cannabis use, including medicinal and non-prescribed use, with treatment outcomes for this patient population. And these are my references. Sorry, Wushan, I wasn't able to cut it down, but I'll work on it this weekend. But thank you everyone for listening. And if you have any questions or comments, I would love to hear them.
Great presentation. I have a question. Do you think that people who use cannabis are like categorically different than those who don't? So it's not necessarily the cannabis that is driving that increased intensity, craving intensity or withdrawal, but something about the individuals themselves?
No, that's an excellent point. And because this was a cross-sectional survey, I don't think we have a way of finding out through this study, but I think it's a really interesting question that you're asking. But unfortunately don't know the answer, but I can definitely look into it. Sorry, that wasn't a great answer, but short answer is I'm not sure.
Well, that's something we can easily do is when we get to the paper is making sure to describe the cannabis subgroups, right? We do, robust clinical characteristics and kind of pick out what we think would be most interesting. Because Hannah's a good point. There's probably a lot of confounding situation going on here. And since it's a descriptive study, we're not trying to draw any conclusions, but it still would be really useful to know how these people look different. And then also look at what you just showed today. So we can easily do that by describing the patient groups and then comparing your outcomes, like you said, exploring the comparisons of the outcomes by these cannabis subgroups.
No, that sounds like a really great idea. Really good point. Thank you.
Any other feedback people have? We actually didn't really know what to say about the findings, actually. I made up something and told you about it, but if anyone has any thoughts on the findings too, and maybe a clinical correlation, we're happy to hear that also, in addition to any feedback on the study itself.
My name is Ryan. I know some of you guys are in my class, but thanks for letting me watch and join in on this meeting. I just think the findings are really interesting because I used to work in harm reduction, and I remember a lot of the patients were saying that they used marijuana and it helped them a lot with their addiction. It was sort of seen as we weren't able to encourage cannabis use, but we also weren't ever you shouldn't do that. And so I think this is kind of not what I was expecting. So it's cool to see.
Yeah, similarly, I also was not fully expecting this because a lot of patients do say that it helps their sleep, especially, and people say oh, I use cannabis for my anxiety. I think one of the patients said that. Yeah, so it's really interesting that it's most likely harmful to their or at least it seems like that because we can't draw any conclusions, but I totally agree with that.
Great. Anyone else have any other feedback?
I like these figures. Sorry, my dogs are barking in the background. No, but I really like that you included these because I think, as Ryan was saying, it provides us with results that I don't think all of us would expect with kind of the knowledge we have in the back of our head. And so especially for an abstract, it's a quick, easy glance to be like, oh, wow, I had no idea it was like that. I mean, I was honestly surprised with the opioid withdrawal symptoms, how occasional use, just from, the people I talked with that would say, oh yeah, use it every other day or use it daily. But, there are people that have been very consistent in their buprenorphine and have, been in remission for a pretty long time. So that was really interesting. I appreciate you sharing this.
I also wrote great figures on my notes to you. So I agree with Livia.
Thank you both.
Awesome job. Well, you're off the hook. Good job. We're excited to show this at the meeting next week.
Hey, thank you guys.
Yeah. Who is next?
I think I'm next. I'm third on the list. So I'm going to share my screen. Can everyone see that?
We don't see it, Phoebe.
Okay, let me open it again. So I'm Phoebe Dacha. I'm a postdoc. I've been working with Dr. Martin since last year. So this is my second project or third project that I'm doing with her. I've
We
enjoyed.
still don't see it. I'm sorry.
Oh, I'm sharing it. I just had to reopen it. Sorry.
Oh, we don't see it.
I had to reopen it. Just give me a second. There it is. Okay.
Great. Yay. We see it now. Thank you.
Awesome. So yeah, as I was saying, I'm a postdoc. This is my second year working with Dr. Martin. I've immensely enjoyed working with her. She's taught me a lot, just research-wise and being a clinician. So working with her now, okay, this is it's part of an ongoing study. So Dr. Martin and Dr. Muller noticed that a lot of the patients that she was seeing, she prescribes them buprenorphine for opioid use disorder. That's the mainstay treatment for it. But what we can figure out is whether they're taking the dose that Dr. Martin and other providers prescribe, or they're taking the buprenorphine based on their own, I guess, what they're feeling like, their craving index, whatever they're feeling like at home. So that brought about this study to examine buprenorphine dosing regimens and its relationship with treatment retention in patients with opioid use disorder. So the background is we all know that buprenorphine is medication that's prescribed for opioid use disorder. It's approved by the FDA, and it's typically prescribed as a once daily medication. But what providers have found is that patients tend to split their doses throughout the day. So it's not quite clear how the dosing patterns affect the outcomes that we hope to see in patients. And that's also not helping clinicians with counseling and guiding counseling and prescription practices. So this study basically is it's a daughter study from a main study that's ongoing from SORT. So what happens is it's a secondary analysis study using cross-sectional data from the SORT study. In the parent study, we're enrolling patients who are ages 18 to 45, and they're all receiving buprenorphine for at least 6 weeks. So before they are enrolled, we do a baseline survey. And in that survey, we do ask them how they're taking their buprenorphine at home and within the 30 days. So the data that we receive, so that we use that data as descriptive statistics data to guide the results for this study. So this is what we were able to find. So we for out of 57 participants, we found that 53% were mainly white, and there were 94% of them were on Medicare, Medicaid. The buprenorphine dosing, which is similar throughout all the presenters, is 6 to 24 milligrams with at least a 2-year length of time that they've been on buprenorphine. So once again, just dividing up what the patients are reporting, their dosing patterns, we found the majority of them were actually taking their buprenorphine at least 3 times a day, as opposed to 1 time a day. That's FDA. I guess that's what the FDA suggests. And then there were 21% that were taking it twice daily, and then less than 1% provided a combination of patterns that were taking it maybe once a day, twice a day, or 3 times a day. And then 8.8% were taking it once a day. So where does that leave us? So in conclusion, it's obviously very, the data is very inconsistent with the once daily dosing that's suggested by the FDA, because there aren't any studies that have concretely studied buprenorphine dosing, essentially. So future studies, we hope to evaluate the correlations of dosing patterns with OUD outcomes, to assess patient reported reasons why they're taking their medication the way they are, and the satisfaction of the various dosing patterns. And I guess, yeah, that's it. Questions?
Great job, Phoebe.
Thanks.
I know that the topic it's simple, but it's so important. We talk about it all the time in clinic, this whole dosing situation. I'll open it up for any feedback that people have about the study.
I had a quick clarifying question and I may have totally missed it, but is it variation in the dosing that they're prescribed, or they're like self-altering that dosing?
Yes, they're self-altering the dosing. So,
Okay.
yeah. I think, well, it's a mixture of both, because Dr. Martin will tell you sometimes, I guess she does prescribe 3 times daily, but we have to also take the data from the providers. And you can do that using, there's like a PMP, so you can compare if what the provider is giving versus what the patient is giving. And I mean, there are so many outcomes that you can look at. Just like, I think when I was thinking about this, I was like 50 steps away, and Dr. Martin had to scale me back down because I was thinking about so many things that you can do with that information. But yeah, so it's a mixture, but I think that the providers do prescribe at times maybe 3 times daily, depending on how the patient presents. You know, if they tell you they're having a lot of cravings, then perhaps they increase the dosing. So Dr. Martin will be able to tell me that. So.
Awesome. Any other feedback that people have?
I think clarifying, is it the person doing the alteration or the provider would be really important. So splitting that bucket of, they might be 3 times a day, but is it prescribed that way or not would be really important to include as a extra variable.
Yeah, thanks. I think that's what we talked about. I just didn't include it on here, but yeah, thank you, Hannah.
Yeah, great feedback. It's an example of, this is such an area that all the clinical providers want more data on, but you can't look at outcomes until you figure out how many people are doing what. So you can't take it to step 10 if you're not at step 1, which is, what are people doing? So we're only supposed to prescribe it in one way, but ask the patients out of their own mouth what they're doing and go from there. So it's a good example of starting a good foundation for Ground Zero for future research. Awesome job, Phoebe. Great. You can unshare your screen. And then who is going next?
I think maybe I'm up next. I just didn't want to. Yeah, I can go next. Catherine, are you okay with that? Okay. Okay, cool. Okay, let me share my screen. Okay. Can everybody see that? I'm gonna make it bigger.
Yeah, if you just make it bigger, it should be fine.
Okay. Okay, can everyone see the full screen?
Yes.
Okay. Okay, great. So my name's Brenna. I'm a third-year medical student at VCU, and I'm working with Dr. Martin and the rest of the team on Project SORT. And the topic of my secondary analysis is factors that promote buprenorphine consistency in women in outpatient treatment for opioid use disorder. So opioid use disorder medication non-adherence has shown to be a problem because it can lead to relapse in patients who have opioid use disorder. One specific study that I looked at actually showed that comparing patients who are compliant versus not compliant on their buprenorphine, 60% of patients not compliant relapse compared to 12% of patients who were compliant on their medication. So this is a relevant problem that can be a focus and has been a focus. So several factors have been studied to determine their role and association with buprenorphine consistency. Some of these that I found that have been studied include patient demographics, patient insurance status, length of time in treatment, other comorbidities, and medication costs. But one consideration that hasn't been investigated is the role that social factors might play and contributing to medication adherence, medication consistency, and decrease the percentage of patients who are going through relapse. So that is why this we're doing the secondary analysis. So the purpose of this analysis is to investigate the role that different social factors, including social determinants of health and recovery capital, might play as predictive factors in opioid use disorder treatment adherence, ultimately to help us to determine the role that targeting some of these factors could play in opioid use medication adherence. So the methods for this project, this is a secondary analysis, data collected from an ongoing cross-sectional survey, including a medical record abstraction study, again, investigating the relationship between sleep and recovery. The inclusion criteria for the study and for the secondary analysis includes non-pregnant women between the ages of 18 and 45 who've been receiving buprenorphine for opioid use disorder for at least 6 weeks. For this secondary analysis, the primary outcome was buprenorphine consistency, and this was measured by patient-reported missed doses of buprenorphine over a 28-day period. Other variables that we looked at for this included the Phoenix Social Determinants of Health Survey, as well as the Substance Use Recovery Evaluator, which is a measure of recovery capital. And then statistical analyses included descriptive analysis, as well as t-test and chi-square tests. So as you'll see, the demographics for our patients, the average age of patients was 33.5. Just over half of our patients were of white race, and a large majority, 95%, were not Hispanic or Latino. Most of our patients do have Medicaid for their insurance, which is pretty typical for this patient population. And just over 50% of our patients were unemployed. And just over 50% had a high school diploma or GED, GED equivalent, and just 4% had graduated from four-year college. So as you'll see from the figure here, this is showing the self-reported buprenorphine consistency over the 28-day period. So the majority of our patients, 84%, did not report missing any doses of buprenorphine over this 28-day period, where 15% did report at least one dose missed of buprenorphine. We also looked, like I mentioned, at social determinants of health. This was a survey that had many questions, but some of the questions were yes or no questions. And so as you'll see in this second table, on the left are the questions and on the right are the percent of patients who responded yes to the question. So Notably, 36% of patients, let me just add, for this, these are just patients who did not miss any doses of their buprenorphine over the 28-day period. So we're looking at kind of the subpopulation of the 84% in the chart above. So 36% of patients answered yes to the question in the past 12 months. Did you ever eat less than you felt you should because there wasn't enough money for food? Whereas only 3% of patients answered yes to the question, do you ever need help reading hospital material? And then, just move this. On the right-hand side of our results are the results from the SHORE questionnaire, which, like I said, measures recovery potential, or sorry, recovery capital. So SHORE scores can range from 21 to 63, and a higher SHORE score indicates a higher level of recovery capital. So within our population, the SHORE scores ranged from 37 to 63. The average SHORE score was 54.8. And as you'll see in this table here, there was a higher SHORE score in patients who didn't miss any doses of their buprenorphine. So the average score of patients who didn't miss any doses was 55 compared to a score of 51 for average score of 51 for patients who did miss one or more doses of their buprenorphine. This wasn't statistically significant with a p-value of 2.93. So as I kind of already discussed, there are many different social factors that can potentially be targeted as modifiable factors for patients to increase buprenorphine adherence and improve outcomes for OUD treatment. Additional research, I think, is needed on this topic to better understand potentially the specific subtypes of social factors that might be helpful to target. For example, health literacy, home environment, transportation, things like that, so that we can have a specific idea of the factors that would be helpful to target in optimizing opioid use recovery, treatment, and adherence.
Great job, Brenna. Love it. I love the strengths-based approach to describing your findings. I will open it up for any feedback that people have about the study and the presentation.
So before I do that, just for the sake of time, let's just do one question and then we can do the questions in the chat. So then Catherine can finish, and in the end, we can come back to Brenna's questions too. Thank you.
Go for it, Rachel. You can be the one question.
Okay. It might just be a clarification question for me. I was just wondering like what the SHORE score is comprised of. I'm not sure if we like went over it or I missed it.
Yeah, good question. So the SHORE score has just different questions about the different aspects of recovery capital. So it tests a lot of different subtypes. So transportation, home environment, like intimate partner violence, just different factors. And each question is given each answer is given a different numerical score that is then added up at the end to determine your SHORE score, which is then analyzed as recovery capital.
Oh, I see. Okay, thank you. And great job.
Great. And the other comment in the chat is kind of similar, and we'll welcome any more comments in the chat about Brenna's study. In general, recovery capital is kind of like a way to quantify someone's recovery. It's kind of arbitrary, right? Because everyone's recovery is different depending on who they are, but it is a way that people try to quantify it. And we know recovery is not just reduced or eliminated substance use. It's also increase in wellness and also citizenship in one's community. So it's a way to try to get at all those factors. It's not a short measure, but there aren't too many recovery capital measures that have been developed, and SHORE is kind of the most comprehensive one out there. So it's the one we utilized. But yeah, we can be more clear, Brenna, about what that is, because not everyone knows what that is. We do, like silly us, but it's not a commonly known thing to other people.
Yeah, that's a really good point.
Mm-hmm.
Thank you all.
Great job. Great. And I'm going to share my screen for Catherine.
Yes, thank you.
You're welcome. There you go.
Alrighty, so my name is Catherine. I'm a second year medical student here at VCU working with Dr. Martin on Project SORT. So what I decided to look into is the role of nicotine use in OUD treatment outcomes. So we know that nicotine use can lead to a myriad of different health problems in just the general population, from lung cancer, COPD, things like that. And we know that nicotine use is highly prevalent among people who use or with opiate use disorder. So I kind of wanted to look at how that might factor into OUD treatment outcomes, because that is not something that has widely been studied. Additionally, we know that cigarette smoking and nicotine dependence symptoms are associated with poor sleep quality. And so that study that I had seen was in young adults who did not have any medical comorbidities. So this study is aiming to compare opioid craving, withdrawal symptoms, and insomnia severity between individuals using and not using nicotine daily among a sample of females with OUD stabilized on buprenorphine. So like we've been saying, this is a secondary analysis on an ongoing survey study. We looked at non-pregnant females between the ages of 18 and 45 who have been on buprenorphine. We utilized a timeline follow back to look at substance use in the past 28 days. So we classified two groups, people who had not used nicotine within the past 28 days, and then those who had used nicotine daily. Our other outcomes were opiate craving, which is a score to see how much someone may have wanted to use opioids, how in control they felt on whether or not they would use opioids if presented the opportunity. And then opioid withdrawal symptoms, and then the insomnia severity index that has been discussed previously. Differences between the two groups were evaluated using a Welch t-test with 0.05 considered significant. So participants were predominantly white with 53.2% and mostly on Medicaid or Medicare for insurance. Median daily buprenorphine dose was 24 milligrams and the median length of treatment time was 2.1 years. So in our daily nicotine use group, there were 32 participants, the majority of which were using tobaccos or cigarettes, and then 8 participants were found to use e-cigarettes or vape on a daily basis. And then there were 10 participants in our no nicotine use group. So you can see our scores in the diagrams here. The opioid avoiding intensity was pretty high amongst our group across the board, as well as they felt very in control of their opioid using. Withdrawal symptoms were relatively low on our score for both groups. And then the insomnia severity score scored as it would, I think it's right on the line of subthreshold insomnia or clinical insomnia in both groups. And none of our values were found to be statistically significant. So to kind of conclude, although not significant, the opioid craving intensity and opioid withdrawal symptoms were found to be higher in the daily nicotine use group than the no nicotine use group. And future studies could look at a longitudinal basis of how nicotine impacts OUD treatment and patient-reported sleep dysfunction, quality of life, and recovery. So I can take any questions or comments. Thank you for listening.
Great job, Catherine. This is such an important topic. Everyone smokes cigarettes or vapes in the clinic, like 100% of people. And my finding that I thought was interesting from yours so far, I guess when it's a small sample, is the no difference in the sleep situation.
Yeah.
Because we know in the preliminary qualitative findings that we've been doing so far with SORT, everyone talks about cigarettes and everyone talks about smoking, and nicotine is a stimulant. So it was interesting that wasn't different, because you would expect it to be different. But I think that might just be because everyone is smoking too. So it's just a bigger group. So I'll open it up with any other feedback that people have about the study or the presentation.
Hi, thank you for your presentation. I just had a quick question. For is it the reason why there are the only 2 groups is because there was no one who used cigarettes on a non-daily basis, like maybe a couple of times a month? Or is it just that they were the only groups?
I'm not sure that we had anyone who said they were using.
So I can also step in because I did
Yeah.
the analysis. So Catherine is
Yeah.
right. It was absolute. It was either daily use or it was no use. So there wasn't anybody in the middle or like using in few days in the last 28 days. So yeah, good question.
Okay, thank you. Thank you.
Mhm.
Also, Catherine, is something I noticed because I also use the ISI, isn't
Mhm.
above 10 clinically significant, like clinical symptom. It's like clinically insomnia, right? So both groups have insomnia.
Yes, I think some of the scoring, it goes in increments of the 8 to 14 with sub-threshold insomnia was what I had seen, but I think sometimes people start treating when you hit 10.
Okay.
I think.
I was wondering if the people who have, or if we know if like the people who have daily nicotine use, like are on some kind of medication to help sleep already because they have that daily nicotine use, and like if maybe that could be like a future like thing to look at.
Yeah, that would be very interesting to look at. I also thought about sometimes with like nicotine replacement therapies and things like that that patients might be on, if that's playing a factor, or even like nicotine dose, which is hard to sometimes quantify with vape and things like that, changing how dosing goes, but definitely things to look for in the future.
And there's another comment on the chat, just kind of focusing on the y-axis for the graphs and just kind of making sure that we are clear about what those mean. So for
Yeah.
like for the opioid craving things, the just being clear, you know, the where the x-axis, the y-axis. So I know for, I think it's a 0 to 100. So
Yeah.
for the avoiding and for the use control goes to 100, but the avoiding can probably just go to 100. You don't need to go to 150.
Okay.
Yes, and it's a VAS, which means like a visual analog scale. So just maybe putting that somewhere on the poster too. It's kind of like a big ticker, and patients just pick where on 0 to 100 they feel the symptom.
Yeah, it was just to accommodate the error bars and the mean value. So that's why for the opioid avoiding, and it went up to 150, but you're right, it's 0 to 100. So yeah.
Lovely. Any other feedback that people have? Great. Well, you were off the hook, Catherine. That's everyone's, that right? Everyone okay? You guys did an amazing job. We are almost on time. It was a lot more presentations than we've ever done in one lab meeting. You guys did all great. If anyone else has any thoughts, like you're just sleeping or in the shower, you're like, oh, I had this great thought about the study, please email the student or email me or Bhushan and let us know. And we appreciate everyone's feedback. And good luck to all the students who are going to be presenting their posters next weekend. And be on the lookout for the meeting invite. Like we said, it'll be, I think it was October 26th at the end of the month next month. So we look forward to seeing you then. And feel free as always to reach out to me and Bhushan if you have any comments or ideas or any other concerns. Thank you everyone for coming out tonight.
Thanks.
Thank you. Bye.
Bye.
Goodbye.